Dr. Arvind.
Yeah. Good evening, colleagues. I'm Dr. Arvind. On behalf of MCure team, I would like to welcome each one of you for today's Eminent 2020 Southern chapter. Today, we have very interesting agenda lined up, and the topic of discussion is rituximab, exploring the other indications. As you can see that we have put together very esteemed faculty and a discussion-based agenda which addresses really topics of highest unmet needs. And to uh, chair today's meeting, we have very eminent course coordinator, Dr. Sampath Kumar sir. He doesn't need any introduction. He's a very eminent senior consultant nephrologist at Meenakshi Mission Hospital at Madurai. And with this, it's my pleasure and privilege to welcome Dr. Sampath Kumar sir for today's meeting. And without a further ado, I would hand over the meeting proceeding to Dr. Sampath Kumar sir. Over to you, sir, and thank you so much for joining us today.
Thank you, Dr. Arvind and MCure team. When people from MCure approached me to have another round of uh, renal transplantation experience in COVID scenario, I said people will lose interest and doze off.
Yeah.
And I asked them, what are the other molecules of interest that you have? And they said that they had rituximab. I thought that there has never been a good discussion on the usage of rituximab in Indian scenario. And I had collected a group of eminent nephrologists who have rich experience in the field. And so I would like to introduce them to this audience. The first one is Dr. Jacob George from the Government Medical College, Trivandrum. He is a professor of nephrology, a very good friend of mine. And the reason why he is chosen as the opening bat is that he has recently published in the Kidney International reports about his unique experience of how he handles rituximab in patients with nephrotic syndrome and in especially in membranous nephropathy and childhood nephrotic syndrome. So it will be very interesting to talk to him and then gather his ideas as to how he handles this molecule. The second participant is Dr. Sundar Shankaran, who is again a very, very prominent and very, I think he is one of the doyens of kidney transplants in the country, pioneering nephrologist of the country. He is head of Department of Nephrology at Manipal Hospital, Bangalore. So he will be sharing his experience on rituximab in renal transplant. The third participant is again a very well-known figure of the Indian nephrology scene, Dr. Edwin Fernando, who is the professor of nephrology at the Stanley Medical College, Chennai. And he has done a lot of original work in the field of nephrotic syndrome, especially in membranous nephropathy, where he will be sharing his experience of rituximab in membranous nephropathy. The fourth participant is Dr. Ilangovan, again a very academically oriented nephrologist of the southern states. He is an alumnus of CMC Vellore, and he will be talking to us about the use of rituximab in SLE and systemic vasculitis as it applies to nephrology. My first experience with rituximab is way back in 2010 when I read the first report of use of rituximab in steroid-resistant nephrotic syndrome in 5 children, which was published in New England Journal of Medicine by Dr. Arvind Daga from AIIMS, New Delhi. And subsequently, Gulati also published along with Arvind Daga his experience of use of this in the childhood nephrotic syndrome, close to 20 children. And the experience gave me some confidence that I can use this molecule in one of the children who really gave me nightmares. because after every 3 months, the child will visit, will be carried by the mother, and after remission, there will be tremendous relapse of nephrotic syndrome. And my backs were to the wall, and I had nothing else to go on. I had used everything. I have thrown everything at him, and he wouldn't budge. Then I had to use rituximab, and I gave 2 doses of rituximab at that time, and the results were really dramatic. The child never returned, and it returned only after 2 years with a relapse, and the relapse was very well controllable with the routine drugs like steroids. So that gave me some confidence, and I started using rituximab in more and more numbers of difficult to treat steroid resistant and steroid dependent nephrotic syndrome in children, especially who are biopsy proved minimal chain nephropathy. I didn't, my experience is not good in patients who had steroid resistant nephrotic syndrome with focal segmental glomulosclerosis, but in steroid dependent and frequently relapsing with difficult to control relapses, this gave me a very good option. The reason why I could have a large number of children is possibly because of the city in which I practice, because the smaller the city that you are practicing, lesser number of pediatric nephrologists will be coming into your city. So we will have to have both the hats of adult and the pediatric nephrology, and that is how I got the experience in that. Overall, the results have been good. The side effects, if you read the published literature about the side effect of this molecule, then you wouldn't be having any confidence in going ahead with the therapy, because the side effects could be unnerving. The starting from hepatitis B reactivation to even cardiac transplantation secondary to enterovirus cardiomyopathy, the side effects could be unnerving, but luckily we have not had any serious side effects in my patients of 22 patients in these last 10 years. So I would have used 1 or 2 cases with rituximab of nephrotic syndrome which are hard to treat. And now I will call upon Dr. Jacob George and ask him as to what are his experiences and how he designed his paper, and what are the important messages that he would like to give for the audience about the use of rituximab as it applies to an Indian context. Dr. Jacob, please.
To share my experience with use of rituximab. So, as we all know, rituximab is a rather new entry to the armamentarium of nephrologists in managing various forms of nephrological problems. But the fact remains that rituximab was first introduced into the pharmacology treatment for treatment of malignant proliferation of the B cells. This is because rituximab is a monoclonal chimeric antibody targeting the CD20 B cells. And this was the reason why it was used in lymphoproliferative disorders and Hodgkin's lymphoma, where you get a malignant proliferation of the B cells, and people are looking for drugs which would specifically target the B cells and not the entire WBC population. And that's how rituximab came into popularity. So mainly, initially it was used in Hodgkin's lymphoma, and subsequently it was branched out to various specialties including rheumatology. They use it frequently for rheumatoid arthritis, etc., hematological problems, and nephrologists have also decided that why not we use this drug. Now, rituximab targets the CD20 antigen present on the B cell, and once it occupies that area, it results in complement activation and activation of the membrane activating complex, which results in destruction of the B cells. And that's how the B cell are targeted by this particular drug, which makes it quite attractive. So the question is, in nephrology, how does this drug which targets the B cell can be put to use? Now we know that several diseases in nephrology are actually antibody mediated. So it theoretically sounds quite good to target the B cells when you feel that it's antibody production which is resulting in the various clinical features of renal disease. For example, in SLE, we all know that's a B cell antibody production. Similarly, in vasculitis, it's true. So this was the reason why we felt that this drug can be extrapolated to nephrological conditions where antibody production is supposed to be a problem. But yet, still it can be used in diseases in which the B cells are theoretically not that much implicated in the pathogenesis. For example, in steroid-dependent nephrotic syndrome and frequently relapsing nephrotic syndrome, we were initially thought that this is a disease of the T cells. And from when I was doing my DM way back in the early 1990s, if you did not say that nephrotic syndrome is a disorder of the T cells, you're sure to fail. But we have come a long way since then, and now we have realized it's not only the T cells, but probably the B cells may also be involved. Because this was, I think, suggested by the, as Sampath mentioned, the early 2000s when it was tried for steroid-dependent nephrotic syndrome and frequently relapsing nephrotic syndrome, and it was found to have dramatic effects. So this suggests that probably B cells may also be involved in this pathogens of nephrotic syndrome. Though there are some people who feel that it's not actually the B cells which is involved, rituximab is directly targeting the podocytes and thereby producing the remission. But other diseases like membranous nephropathy, where we come to realize that it's an antibody directed against a PLA2R, which is implicated in the pathogenesis. So here also theoretically B cell therapy could be of use. And vasculitis also because of antibody production and SLE. These are also conditions where one would theoretically feel that B cell therapy would be useful. Now, renal transplant is again a different scenario. So what would be the role of rituximab in renal transplant? ABO incompatible is one which will strike our mind because naturally we want to reduce the production of antibodies that is a blood group. And it has been initially tried in ABO transplantation following splenectomy, and people found it as an alternative to splenectomy. And they used it at the same dose used in lymphoproliferative disorders. That's 500 milligram probably every week for almost 4 weeks. This was the initial experience with rituximab in ABO incompatible transplant, and then they decided that with rituximab one need not really do a splenectomy and go ahead with ABO incompatible transplants. Now, antibody-mediated rejection is another vexing problem which nephrologists face, where the antibody is one which is producing the kidney, the graft damage. So here also rituximab has been used, and it's especially useful in the acute antibody-mediated rejection, though in the chronic it's not found to be that useful. Now, what does it have a role in the induction therapy? Now, the induction therapies are traditionally directed against the T cells. You have got basiliximab, and you have got the anti-thymocyte globulin, etc., which predominantly targets the T cells. So, but we come to know that this cell-mediated rejection has come down. It's mainly the B cell rejection, antibody-mediated rejection, which is also not only producing long-term graft loss, but also early graft also is seen with antibody-mediated rejection. And there's the incidence of cell-mediated rejection has definitely come down. So now there is a lot of feeling that probably induction therapy we should be including a B cell targeting therapy. So here also let us look at the role of the rituximab has got a role as an induction therapy in renal transplantation. Now the question comes is, what is the dose and frequency which is appropriate? Now in lymphoproliferative disorders, the dose used was a pretty steep dose, 375 milligram per meter squared, given every week for 4 doses. Now this, because this was the dose recommended in the pharmacopoeia based on the experience with Hodgkin's lymphoma, nephrologists decided that the same dose should be extrapolated to nephrology use. But is that the right thing to do? Because we know that nephrology conditions like SLE, lupus nephritis, membranous nephropathy, there's really no malignant proliferation of the B lymphocytes. So in that case, do we really require the same dose and frequency? Because here we have got a normal B cell population. And the other important question is, shouldn't we be monitoring the rituximab dose as done with other drugs like cyclophosphamide? So we have been taught that before using cyclophosphamide, one should look at the total count, and unless the total count is 4,000 or at least more than 3,000, one should not give cyclophosphamide. And there are studies here suggesting that your dose of cyclophosphamide should be targeted based on the nadir total count at the end of 2 weeks. So suppose you are giving 750 milligram or 500 milligram of cyclophosphamide at the end of 2 weeks, your total count is 6,000, 7,000. That means your dose is probably inadequate. And on the other hand, if you are giving 500 milligram and at 2 weeks, your total count is less than 3,000, probably your dose was too much. So this was the traditional method of monitoring cyclophosphamide. And why is this not recommended for rituximab? That was the question which I was always worried. And I was always thinking of why we should be, because we have got a method to monitor the rituximab. So why this recommendation is not there? Why people are not recommending monitoring the CD19 or CD20 count and then targeting your rituximab dosage? That as Sambat mentioned, there are some side effects of rituximab. Generally, it's well tolerated. The most common is a drip reaction and allergic reaction is not much of a problem, but generally you have to give hydrocortisone, Avil, and probably paracetamol before starting the drug. But generally, most of these are very mild and not matter of concern. Infections, rituximab is supposed to produce a subsequent, depletion of the B cells, and so they are prone for infections because of less of antibody protection. People get reactivation of hepatitis B. And now there is a feeling that in COVID era, rituximab may have a problem because one thing is if you get, once the COVID vaccine comes, they may not develop an adequate immune response because the B cells are suppressed. And also whether it produces a permanent COVID infection, there was a initial fear, but now the most feeling is that mainly a T cell depletion produces COVID flare up, because we know that thymocyte globulins and mycophenolate are the drugs which produce a flare of COVID. So B cell is not supposed to theoretically at least produce a COVID infection, but however, whether it will affect the vaccine response is a matter of concern. The more worrying problem of rituximab side is that it can rarely produce progressive multifocal leukoencephalopathy. And what is worrying about giving further doses of rituximab is that some of them can develop rituximab antibodies. So a second or third dose may not be effective. So all this makes it all the more important to decide to use the minimal dose and lesser frequency of rituximab, especially to prevent anti-rituximab antibodies and long-term B cell suppression. Now we have got methods to monitor rituximab. Even though rituximab targets the CD20 is generally seen in the mature B cells. The early forms of B cells and the plasma cells do not contain CD20. You have mainly CD19, so that's why people are now relying more on CD19. When you do ask for the laboratory CD19 count, actually you get a bit confused because they ask you, do you want total, do you want percentage, do you want absolute? So we are a bit confused. So for the benefit of the PGs, let us just discuss what is this total percentage, what is this absolute CD19 count. Now, if you actually look at the B cells, they are the lymphocyte, leukocyte. The total leukocyte count is approximately 4,000 to 11,000 is normal leukocyte count, but this includes polymorphs, etc. And lymphocytes, if you look, the absolute lymphocyte count is only a small percentage of the total leukocyte count. So it comes to approximately 990 to 3,000 cells per microliter compared to the total leukocyte count. So the lymphocyte count is definitely much less than the total leukocyte count because we're excluding the neutrophils, eosinophils, etc. Now, of these lymphocytes, the majority are T lymphocytes. So if you look at the B cells, of this 990 to 3,150, only a small percentage is actually B cells. It comes to only around 99 to 527. So when you ask for an absolute B cell count, you'll be getting a value like this, and from this we can decide whether B cell is suppressed or not. What is more reliable than the absolute CD count is to look at the B cell percentage. The B cell percentage would be the absolute CD count divided by the absolute lymphocyte count, and will give you a percentage. So for example, if you divide 99 by 990, you'll probably be getting the value like this, 6,222. And this particular patient had an absolute CD of 172, whereas his absolute lymphocyte count was 5,550. If you look at calculate the percentage, it's actually calculated value. The total B cell percentage will be only around 3%. So this is what is the laboratory measures as a CD percentage. So this is important because we are monitoring the rituximab. Now, this monitoring of this CD9 count is important for whether to decide on initial dose and subsequent dose. Like as I was mentioning, cyclophosphamide, we have been deciding whether the total count is more than 4,000, then giving a cyclophosphamide, and this total count is less than between 3,000 and 4,000, probably giving a lesser dose. So does the same thing hold true with rituximab? Generally, people do not monitor the CD19 count before giving rituximab, But I think now, because the CD9 count can be done relatively cheap, only cost around 3,000 rupees. So probably one can look at the CD9 count and decide on an initial dose, whether it should be a high dose or low dose. But more importantly, it would be to give a subsequent dose, because if your CD9 cells remain suppressed, then the theoretically at least doesn't sound at all logical to give a subsequent high dose, especially if the CD9 counts are suppressed. So this is the main role for targeting your rituximab therapy based on CD9 counts. Now, I think we have to salute these authors, Remusi, Rugenti, etc., from Italy. And way back in 2007, see, it's 2007, they themselves looked at this method of titrating rituximab to circulating B cells. At that time, they looked at CD20 B cells. And they decided, why not we look at CD20 B cells and decide on titrating? And they compared it with a standard protocol of 4 weekly doses. And they found that once they monitored the CD20 B cells, they found that only one patient needed a second dose, which is a really amazing result. And they found that the costs could be brought down to as much as 10,000 euros to 13,000 euros savings per patient, which is really remarkable. So their conclusion was that avoiding unnecessary exposure to rituximab is extremely cost saving and may limit the production of anti-chimeric antibodies, which is the thing which I was mentioning. Now, this was published in a reputed journal, CJAS, in 2007, but unfortunately, I feel that it was swept under the carpet and nobody gave any importance to this article, because they've got several mega trials and key clinical trials on rituximab, and all of them have used the same dose which we have been using in lymphoproliferative disorders, and nobody gave any heed to Rugenti's and Remusi's landmark article. So I've got the RAVE study in vasculitis, which Ilangon will be highlighting on, the RituxVas, the Mentor study, which is again a key clinical study in membranous nephropathy, the GemRutux, all these have used the same dose which we use in lymphoproliferative, a high dose, and repeated doses. They give it very frequently, weekly, for almost 4 doses, and without any monitor of CD9 count, it doesn't at all sound any bit logical as far as I am concerned. So these are the clinical trials reported in a reputed journal like New England Medical Journal of Medicine, used the same dose and gave rituximab without any monitoring and found significant remission, which is, of course, the question is, had they monitored and given a lesser dose and less frequency, would it we also have been able to manage this amount of remission with a lesser dose and lesser frequency? This is the thing which I think future trials should be looking at. Now, this is the Mentor trial. Everybody describes the Mentor trial, but look at the dose of rituximab they used. 1,000 milligrams. That's 1 gram, 2 doses apart at 14 days interval. Now, is this really justified? They also never monitored the CD19 count. Now, let us look at our experience. I think we felt that with the facility to do CD9 count and the cost also relatively less, so we can do it for 2,000, 3,000 rupees. And when pharma companies said that rituximab is available, it's 500 milligram, which costs 30,000 rupees, and you've got 100 milligram, which costs 6,000 rupees, and Tirunelvelam Medical College handles very economically backward patients. So the question is, shall we try 100 mg and shall we monitor it with CD19 count to see whether your dose is adequate, or are we not justified at all using 100 milligram, and should we be really using the high dose recommended in lymphoproliferative disorders? So this was the study, this was the thought which we felt, and we considered why don't we try with monitoring CD19 count. So we looked at 42 adult patients. They included 30 steroid dependent and frequently relapsing nephrotic syndrome, 5 patients with membranous nephropathy, and 7 kidney transplant patients who are at high immunological risk. So prior to, as an induction therapy, we used it in 7 patients, and we just gave 100 mg rituximab, and we gave rituximab after monitoring CD9 count and looked at the CD9 count after 30 days. And we found that almost 95% of them had CD9 count less than 1%, which is significantly low. So the question is, are we really justified in giving a subsequent dose of rituximab with 100 mg is produced total suppression at 30 days. And by 90 days, almost 50% remain suppressed. And they almost 6 months later, almost 1/5 of the patients still had CD19 count below 1%. So look at this 1/5 of this population. We would have unnecessarily giving their high dose of rituximab 500 mg every frequently. We could remind the cost of rituximab 30,000 rupees given for every weekly for 4 doses. Was it really justified? Because just 100 mg is produced in 20% of the patients, even up to 6 months total suppression of the CD19 less than 1%. So in our study, we included steroid dependent nephrotic syndrome, almost 27% persons, 7 frequently relapsing nephrotic syndrome, 5 membranous nephropathy, and 7 high immunological risk renal transplant. We used just 100 milligram rituximab after we checked the CD9. So we checked the CD9 count just prior to rituximab, and after 30 days, we monitored the CD9 count on 30 days, 90 days, 6 months, and 1 year. And we decided when we give further doses if the counts were, there's a replenishing of the B cell CD9 count, and again, depending on clinical response. Like suppose the person had a relapse and the CD9 count still was low, we probably would have decided on giving a subsequent dose. And we targeted the CD9 count to be suppressed if it was less than 1%. This total percentage of CD9 count less than 1%, we said it's suppressed, and more than 1%, probably you would consider a second dose depending on the clinical response. Now let us look at our observation. You see that at day 30, you find that almost 93% had total suppression of the B cells, and 96% of them went into complete remission. By third month, you find that almost some of them, two-thirds of them had replenishment of the B cells, but still in almost 1/3, it was still suppressed at less than 1% at 90 days, and almost 96% of them were in remission. And by day 180, again the CD percentage count, there was a replenishment, but still 76% of them continued to be in remission. So this is again suggesting that lesser dose of rituximab and lesser frequency may be sufficient in frequently relapsing nephrotic syndrome, probably provided you monitor the CD9 count and clinical response. Now, of the 27 steroid dependent and 3 frequently relapsing nephrotic syndrome, 100 mg of rituximab was given. At day 30, you find that almost 28 out of 30 had total suppression of the B cells. Of this, 1% received an additional dose because he failed to respond. 1 person who did not respond again received an additional dose. And by day 30, 29 were in remission. And by day 180, 23 out of 29 maintained remission, and 6 patients relapsed and these patients received an additional dose. So we find that at the end of 1 year, 2 patients relapsed, so we gave an additional dose again to these patients. So none of these patients required more than 2 doses of rituximab in steroid-dependent nephrotic syndrome. So that is again a significant economical advantage. Now this, our observations were again replicated in another study, again present in JASN. And look, they found that 1 dose or 2 doses of rituximab 375 milligram, and at 11 years, all patients were in remission, 18 were treatment free, and 15 never relapsed. Again, suggesting that using every week for 4 doses doesn't sound at all logical, and definitely it will drain your money without any benefit and possibly increase side effects as well. Similar observations again reported by a Japanese group where they found that a semi-annual, they used semi-annual 100 mg rituximab, and they found that semi-annual with a single fixed rituximab dose of 100 mg, complete remission was obtained in 3 cases. So I agree it's a small number. So now what is the observation in membranous nephropathy? See, in membranous nephropathy, again, we used it in 5 patients. At day 30, almost 100% of them had CD cell suppression. And by day 90, 50%, 1/5, 20% had suppression of the B cells. But if you look at the clinical response, you find that almost 80% of them went into remission. But at day 180, again in remission, partial or complete, but 1 person actually failed to respond, and he failed to respond to a high. We thought that since he failed to respond to 100 mg, should we not be giving 500 mg? But we gave 500 mg and he still failed to respond. So this suggests that probably this person may be in remission. So a person who is not responding to 100 mg may not respond to 500 mg. And probably a person who is responding to 500 mg would probably may have responded to 100 mg. So this is something which has to be looked into, but we have now we have got only 5 patients. So the argument is that probably these 5 patients were the group which would probably have responded early and the better prognosis. So we require more patients before we can make a definite recommendation. And we feel that 100 mg rituximab in membranous nephropathy of 5 patients, 4 achieved remission by 6 months, which is sustained in 3 by 1 year. Again, suggesting low dose may be sufficient. And this was again substantiated by the Italian group, where they again found that single or 2 doses is still effective in membranous nephropathy. One need not be giving high dose. And this observation was also replicated by the PGI group, Raja Ramachandran. They used 100 mg of rituximab, and 3% achieved complete remission with proteinuria normalization and serum albumin. And mean time for replenishing B cells was approximately 2 months. Again, suggesting 100 mg may be sufficient in membranous nephropathy. What about renal transplantation? Renal transplantation, we used it in 7 high-risk renal transplantation patients. And we found that in such patients, the CD cell was suppressed for almost a year. Just 100 mg was sufficient to produce a total B cell suppression. So suggesting that 100 mg may be sufficient. And again, using 500 mg in renal transplant may not be required. Compared to membranous nephropathy and steroid-resistant, steroid-dependent nephrotic syndrome, the CD cell suppressed will be more in renal transplant, probably because they were using other immunosuppressive drugs which are suppressing the bone marrow. This may be one explanation. So, ladies and gentlemen, we feel that 100 mg rituximab may be sufficient, provided you monitor the CD9 count and depending on the response. And probably membranous nephropathy, we agree the number of patients were less, but probably one could try with 100 mg, and if they fail to respond, go for a higher dose if warranted. So thank you, and I'm happy to hear the experience of others in this field as well.
Thank you, Jacob, for really a paradigm shifting study where you've shown the world that the lower is as good, lower dose is as good than without producing serious adverse effects. So we'll pass on to Dr. Sundar, and he will tell us about the use of rituximab in renal transplantation. Dr. Sundar?
At the outset, let me thank Sampath, my brilliant colleague and good friend from Madurai, for inviting me to be part of the MQF program. And I must also acknowledge that whatever immunosuppressive protocol I've been using in the last 35 years, a lot of credit should go to my colleague, Dr. C.M. Tyagarajan from Vellore, who taught me how to use cyclosporine way back in the 80s. And also Dr. Hariharan, my classmate, who's done a lot of work on transplantation. And in fact, recently, it's one of his papers on rituximab. It's a review paper has just come in 2018 in transplantation. I'm going to talk on that. Now, when you talk of any immunosuppression in transplantation, if you listen to Flavio Vincenti from San Francisco, he says ideal immunosuppression should be selective novel mechanism to block both T and B cells. It should be non-nephrotoxic. It should not promote malignancy. It should not aggravate cardiovascular risk factor. It should improve compliance. So when you look at all this, I think rituximab probably falls into that category. Now, Jacob has given an excellent review of the whole scenario of rituximab. In fact, I think we are all now redundant. We don't even need to talk and discuss because he has done it so beautifully. I must acknowledge that because he has not only talked about his paper, he has discussed the various aspects and he's even discussed about transplantation. Now, all of us know that rituximab is an anti-CD20 molecule, how it works. One of the three methods, they say how the B cells get depleted, either by antibody mechanism, complement mediated, cytotoxic mechanism, and apoptosis. That's how the B cell go away. And if you look at the dose use, we all learned from the oncologists. They use very high dose. Whatever it is, whether rituximab or any other medication, everolimus, the dose they use, actually, our patients will be dead. In fact, my colleague Tyagarajan tells me, if you follow the oncology dose, patient pusingipedoises in Tamil. That means the patient will actually become an ash, which is true. We can't use that sort of dosage. In fact, when we started transplant with cyclosporin, the dose used was 15 milligram per kg in 80s. And Tyagarajan, one who suggested use only 4 or 5 milligrams per kg, based on his discussion with Dr. Manikam Sudhindaram from Cornell in US. So in India, I think scenario is different. And I'm very happy that Jacob has actually brought in the low dose concept. And if you look at the Hariharan's paper, which I just went through, he gives, importantly, rituximab in transplantation, 3 scenarios. The first scenario is desensitization technique. Most of the desensitization technique, earlier days was only plasmapheresis and various other ways. Now rituximab is part of the protocol. Others, ABO incompatible transplant. I think Jacob has actually discussed how ABO incompatible transplant. Japanese people use low dose, 100 milligrams should be enough, that's what they say. And the effect of that, if you see Jacob's study itself, goes on for many months. And there is evidence to show the effect can go on up to 2 years. A single dose of 100 or 200 milligram rituximab, the effect on the B cells can go up to 2 years. The other scenario where rituximab can be used as per Hariharan and my own experience is antibody-mediated rejection, especially acute antibody-mediated ABMR. There is evidence that rituximab could be effective, and we have used, initially I was using the high-dose protocol, but now I use only 100 or 200 milligram rituximab. Then comes rituximab in induction. I think that is a very important topic, which is a hot topic, I would say. And again, my friend Tyagarajan only told me, please use, you got T cells, B cells. For T cells, use small dose thymoglobulin. For B cells, use small dose rituximab. I think it makes sense. In fact, my colleague, Dr. Vishwanath from Manipal tells me that they have been using thymoglobulin, and for some reason, they noticed more evidence of ABMR in their cases. And now recently we have started a protocol of using a small dose of rituximab along with thymoglobulin. So we'll get to know in a couple of months after a few hundreds of transplant what exactly happens. So it makes sense. I think scientifically, if you look at the evidence, combining a small dose of rituximab, small dose thymoglobulin would make sense in induction. I think that is one. Definitely, if you look at the other indication in transplant is recurrence of glomerulonephritis after transplantation. In fact, Hariharan tells me that FSGS, vasculitis, membranous nephropathy, the effect of rituximab is excellent. But he has doubts whether rituximab will work in recurrence of IgA nephropathy or MPGN. So he recommends definitely in recurrence in FSGS, membranous nephropathy and vasculitis to use rituximab. One other way, definitely there's no contraindication, is where we deal with oncology problem. PTLD, post-transplant lymphoproliferative disorder, where rituximab definitely works. In fact, the lesions disappear like melting butter when you use a hot knife. So these are definite indications for using rituximab. Now, this is Hariharan's own experience. But then what I did was I did a survey with my own nephrology association. I wanted to find out where rituximab is used in transplantation in Karnataka. Most of them agree that if there has been a positive DSA with high MFI, they would use rituximab as induction in addition to thymoglobulin. Many of them say that they would also use rituximab in antibody-mediated rejection. Definitely they would use. They also say that highly sensitized individuals, people going for second transplant, many of them use prophylactic. And again, the dose, we certainly don't know what exact dose to be used. We need more studies. I think study like Jacob George's study is very important. And then only maybe we could also come in this discussion, arrive some sort of consensus, what dose we should use, when should we use, how long should we use, we should be using every week, every month. I think these are questions which keep coming into my mind. And I think I would not go further. I would request Sampath to go on to the next topic, and we go on with the panel discussion and learn more from our colleagues. Thank you, Sampath.
Yeah, thank you, sir. As usual, we'll go on to Dr. Edwin, who will be talking to us about how he uses rituximab in membranous nephropathy. Dr. Edwin, please.
Good evening, all. Thank you, Sampath. My respects to Dr. Sundar and Dr. Jacob and the MCure team. I shall be talking to you about, I'll share the literature available on the use of Ritux in membranous nephropathy. My experience has been very small. It's not been that very great. So I shall just share what is available in the literature, what I went through, and some critical analysis. I hope you can see my screen.
Yeah.
So over the next 15 minutes, I shall be addressing this topic under the following headings. So we know that cyclophosphamide-based regimes are associated with significant toxicity and long-term risk for malignancy. The modified Ponticelli regime entails approximately about 9 to 13 grams of cyclophosphamide for a 70 kilogram adult. And the toxicities are cumulative. So for a disease with relapsing nature, this is not an attractive option. So we know what is rituximab. It's a chimeric monoclonal antibody directed against the CD20, which is present on the surface of an disease. These are the landmark trials available in the field of membranous nephropathy right from the time Hayman's nephritis was picked up in 1959. I shall concentrate on these 4 trials: the GEM-Ritux, the Mentor, the recently done Starman, and the Recyclo trials. In studies, it has been shown that there has been a favorable response of rituximab in membranous, a complete and partial remission rates of nearly about 60 to 65%. The median time to remission is approximately 7 months. And this is a recent editorial that spoke very highly about rituximab. Cyclophosphamide and cyclosporin have to go, and rituximab is here to stay. I shall talk about the GEM-RETUX trial, which was one of the first trials that came out on this particular area. This is a study of about 80 patients of membranous nephropathy, multi-center, control, open label, randomized, 31 hospitals. And this was compared the primary and secondary outcomes of complete or partial remission. Secondary outcomes were anti-PLAR antibody depleted patients. So what happened here was the positive effect of rituximab on proteinuria remission occurred after 6 months. And these data suggest that PLA2R levels are early markers of rituximab effect. And the addition of rituximab to the ACE-ARB conventional group does not affect safety. Well, there are some criticisms of this study. It missed the primary endpoint. At month 6, 35 patients on rituximab and 21% of patients on conventional antiproteinuric treatment achieved a complete remission or partial remission. Thus, it appears that rituximab appeared no different than the antiproteinuric therapy alone. The design of the study was criticized. It was flawed and not adjusted to the current understanding of the pathogenesis of the disease and the mechanism of action of rituximab. And the 6-month time point was unrealistic for therapeutic success. The other major trials since 2019 have been the Mentor trial, which studied rituximab and cyclosporin, the Starman, the more recently published one that checked out modified Ponticelli versus tacrolimus and a single dose of rituximab, and the Recyclo trial that's not been formally published but presented, the Recyclo trial that compared modified Ponticelli and Ritux. This is the Mentor trial. It was published in 2019. So this is again 22 sites in North America, biopsy proven, membranous 5 grams of proteinuria, creatinine clearance more than 40. So day 1 and 15, we were given Ritux. Second course was done in some. Cyclosporin was the other group. So this is a randomized non-inferiority trial comparing cyclosporin to rituximab. It was found that Ritux was non-inferior to cyclosporin in inducing complete or partial proteinuria remission at 12 months and was superior in maintaining long-term proteinuria remission up to 24 months. So this is what they found out. So it was shown that there is response in about 12 months. And what is important was the proteinuria remission was achieved up to 24 months. What we learned from Mentor is a preferred initial therapy of apparently primary membranous compared to cyclosporin after 24 months of observation. It's well safe and well tolerated over the short term. However, there is a 40% failure rate at 24 months for Ritux and an 80% failure rate of cyclosporin at 24 months. That indicates that additional unmet needs in the treatment of membranous nephropathy are still there. So this trial also had its fair share of criticisms. It was not blinded to the patients and treating physicians, though the objective lab data that formed the primary outcome was blinded. The level of anti-PLA2R in non-responders was not looked into. And what would be the change in response rate if the non-responders in both arms at 6 months had continued with therapy? That has also not been studied. Ideally, Mentor should have had Ritux versus steroids and cyclosporin, which was addressed by the Recyclo trial, about which we'll discuss later. Again, whether this study with the results would be same in all races was not very clear. How was the positive threshold of the anti-PLA2R was determined? And for future trials, is there any other standardized approach to measure this particular analyte? This is also not clear in this study. So what we can't learn from Mentor, what is the influence of spontaneous remission on results? So there is no placebo control, which a person like Richard Glassock feels it's unethical. What is the efficacy and safety of Ritux in comparison to cyclophosphamide-based regimes? What is the influence of anti-PLA2R positivity or negativity on efficacy? There is no stratification of the levels. Is there any clinical value of monitoring CD19 or 20 B cells in circulation? Would more prolonged cyclosporin therapy or more repeated dosing of Ritux influence the results? And of course, the ultimate point is, will Ritux therapy prevent ESRD? This has not been clear in this trial. Then coming to the more recently published Starman trial. So this studied 86 patients, biopsy-proven membranous, proteinuria more than 4 grams, eGFR more than 45. 43 patients were on the conventional modified Ponticelli regime. Then there was a 6-month observational period before that it was started. Then there was the other 43 patients had oral tacrolimus full dose for 6 months and tapering for another 3 months, and 1 dose of Ritux given at month 6. So the conclusion from this trial was treatment with corticosteroid and cyclophosphamide induced significantly more remissions of nephrotic syndrome than treatment with tacrolimus and rituximab. So this particular study still upheld the value of the modified Ponticelli regime. However, there are criticisms about this also. This is not an ideal comparison of Ritux versus cyclosporin because only 1 dose of Ritux was given, plus a course of tacrolimus. Hypothesis is it would reduce disease recurrence once the CNI tapered off. So was the response to, what was the response to CNI? Very clear, is not again well described. Starman should have had only rituximab against cyclosporin and steroids. Should the non-responders have a redosing of Ritux because there is only 1 dose was given? The rate of adverse effects actually higher in the cyclosporin and steroid group, though it was not statistically significant in this trial. Then coming to the recyclo randomized trial, which studied rituximab versus cyclophosphamide. So here, this was studied for about 84 months, follow-up of 36 months. They were randomized to the conventional modified Ponticelli regime versus rituximab given on day 1 and day 14. So the conclusions were either arm failed to show any difference in terms of benefits and harm, while non-significantly different analysis according to intention to treat analysis, 1-year probability of CR was lower in the Ritux arm in the post-publication analysis. While considering CR and PR together, no difference between arms throughout the follow-up suggests that the cyclical regime in the modified Ponticelli may induce remission earlier, and frequency of adverse events were comparable. The criticism about this study was there was no data regarding the redosing of Ritux. So this is a more recently published meta-analysis of Ritux in membranous nephropathy. 21 studies analyzed, 602 patients, mean age 50, 30% were females, a follow-up duration of 20.3 months. The remission rate was as high as 67%. Rituximab therapy significantly reduced proteinuria, nearly a 62% reduction in proteinuria. The reduction in proteinuria was inversely associated with the baseline serum albumin level and eGFR, and positively associated with baseline proteinuria. Remission rate or decrease in proteinuria was not significantly related to the anti-PLA antibody status or previous immunosuppressant therapy. So the rituximab has been studied in patients with membranous nephropathy who had CKD also. So here 14 patients who underwent rituximab therapy were studied in this particular study. It seems effective and safe even in PLA2R positive membranous nephropathy in stage 4 or 5 CKD, and immunological remission is associated with good clinical outcome. Now, what are the dosing regime and therapeutic responses studied? These were the different regimes that were studied. 1 gram IV, day 1 and day 15, repeated course at 6 months. 375 milligram per meter squared at 1 week interval, every week for 4 weeks, and then single dose following and follow the B cell counts. So what should be the ideal rituximab dose optimization? Both Mentor and GEM-Ritux tested a multiple dose Ritux regime, 2 consecutive 1 gram doses separated by 2 weeks, and 2 consecutive 375 milligram per meter squared separated by 1 week respectively. In their paper by Ruginenti from Italy, he advocated a single dose regime termed as the B cell driven rituximab treatment and prescribed a second single dose based on B cell depletion and proteinuria response. Most membranous nephropathy patients clear the circulating B cells within 24 hours of a single 375 milligram meter squared dose, questioning the need for the initial repetitive dosing. Single dose regime may achieve long-term complete remission or may be followed by a second single dose if B cells are not depleted or following recurrence or partial remission. Does rituximab regime influence remission rates in PLA2R related membranous nephropathy? So here, the PLA2R antibodies were measured by ELISA, and here it showed that higher dose Ritux protocol is associated with more complete depletion of B cells and higher rates of remission of PLA2R related membranous nephropathy, and the lack of epitope spreading was associated with remission in both cohorts. So this is again a study from Beck et al., the original researcher of the PLA2R antibody. Here they looked at the months following treatment with rituximab, and the rituximab-induced depletion of anti-PLA autoantibodies predicts the response in membrane. So on the left of the screen, you see the decline in advance of a more gradual decline in proteinuria. And the B shows in those patients who cleared the anti-PLA antibody, the proteinuria reduces. So some other important considerations with Ritux: it's lost in urine in patient nephrotic syndrome compared to non-proteinuric subjects. Inter-individual variability of residual Ritux serum levels may depend on the efficacy of recycling by endothelial cells via the FC receptors, which might be influenced by polymorphisms in the FC receptor. The other one size does not fit all theory also holds good. The rate of partial remission lower with Ritux than cyclophosphamide. Ritux is less effective in inducing immunological remission in patients with high levels of anti-PLA1 or multi-domain recognition. Majority of these cases seem to respond to a second course of Ritux. If Ritux is chosen for treating severe disease, one should consider using a high-dose regime, 1 gram at 2 weekly intervals, repeated at 6 months. Anti-Ritux antibodies have also been studied. This is a neutralizing anti-Ritux antibody and relapse in membranous nephropathy treated with Ritux. All monoclonal antibodies can elicit anti-drug antibodies, which may interfere with therapeutic response. This study analyzed relevance of anti-Ritux antibodies and the outcome of membranous after a first course of Ritux. So 44 patients who were treated with 1 gram infusions of Ritux on 2-week intervals. Anti-Ritux antibodies, CD19 and clinical responses were analyzed. What was found was anti-Ritux antibodies were significantly associated with faster B cell reconstitution at month 6, higher proteinuria 12 months after rituximab infusion, and the response rate 6 months after rituximab was not different according to the anti-rituximab status, but the rate of relapse was significantly higher for patients who had anti-Ritux antibodies. Patients with anti-Ritux antibodies frequently required a second course of Ritux infusion. Is humanized anti-CD20 a satisfying therapeutic alternative? Anti-Ritux antibodies neutralized rituximab activity in 8 of 10 patients and cross-reacted with other humanized monoclonal antibodies in only 2 patients. Second and third generation anti-CD antibodies like obinutuzumab and ofatumumab that bind to different epitopes of the CD20 molecule have been developed. And there have been some preliminary reports that showed the efficacy of ofatumumab in rescuing patients with Ritux-resistant membranous nephropathy. Safety issues with rituximab, neutropenia, pancytopenia, hypogammaglobulinemia, progressive multifocal leukoencephalopathy, of course, rare, cardiomyopathy, pulmonary fibrosis, opportunistic infections. Recently, I saw somebody who had an interstitial pneumonia secondary to Ritux. However, there are unmet clinical needs and many unanswered questions in the treatment of primary membranous nephropathy. The relative position of rituximab versus cyclophosphamide steroids as first-line therapy. Long-term rituximab outcomes, preservation of renal function, progress to ESRD have not been studied. Timing of the initial rituximab, the indication, and the optimal dosing is again not very clear. Many regimes have used many doses. Adjuvant therapy to accelerate remission while the disease-modifying effect of rituximab sets in should be considered. Alternative regimes for Ritux treatment failures or improve Ritux efficacy record without compromising safety should be addressed. And the role of serum anti-PLA2R antibody specificity or titers in the individualization of immunosuppressive therapy should be looked into. So I come back to this editorial once again, which spoke about treatment of idiopathic membranous nephropathy in adults. KDIGO 12, cyclophosphamide, cyclosporin out, rituximab is a new norm. Well, look at these data, stop and rethink the strategy. Thank you very much for the patient listening.
Thank you, Admin, for taking us through the intricacies and controversies of using rituximab in membranous nephropathy. Another huge chunk of patients are the group of vasculitis and lupus. What is the exact role and the place of rituximab in these groups of patients? To dwell on these, Dr. Ilangovan will be talking to us. Dr. Ilangovan, please.
Thank you, Sampath sir. At this outset, I would like to thank MKR and Dr. Sampath for giving the opportunity to talk to all. And I'm quite delighted to have listened to Dr. Edwin, Dr. Jacob, and Dr. Sundar. So quickly, I think I'm the tail end of this show. So I'll quickly take you to the rituximab use in SLE and vasculitis.
Ilangovan, it is the tail-enders who are really useful in India. Today, the tail-enders only lifted India up. So don't feel dejected.
Yes, sir, yes, sir.
Tail-enders. Go ahead.
Yeah, thank you, sir. Thank you for that. So rituximab in SLE, first is SLE, the more common one than the vasculitis. And the rituximab has been used by many in refractory lupus nephritis. And there are many anecdotal reports like this one, which showed that in a single center, not only the disease activity, but also proteinuria, the hematuria, microscopic hematuria, and also kidney function, all improved with rituximab. So there are innumerable number of studies published, all which clearly showed benefit or so much so that the EULAR and other people looked at rituximab as an induction agent in even less severe ones, like not only in refractory, but also in moderate to severe active SLE. And this exploratory trial, mostly non-renal patients, where they've showed that there was no significant difference between placebo and rituximab in primary and secondary endpoints. So the whole world, which was looking up to this, it was sort of an anticlimax that it didn't contribute much. So then more renal specific trial, the LUNAR trial, looked at the role of rituximab in SLE induction therapy. Again, here also, the conclusion was that rituximab therapy led to more responders, greater reduction in anti-dsDNA C3, C4, but however, it did not improve the hard endpoints like partial remission and complete remission. And the combination of rituximab with MMF and steroid did not result in any new or unexpected safety signals. So that was something, at least a take-home point, where that's good news about it, that it did not contribute to side effect. But sometimes good things don't come out when the methodology. In fact, when I tell anybody who want to do a research work is that it's only the methodology that's the hero of any trial, and you get it wrong and you get the wrong result out. And I think Lunar has some things positive, positive to take, even though the complete renal remission, partial renal remission was no different with rituximab versus placebo. But and also other secondary endpoints like proteinuria reduction in patients who had nephrotic range proteinuria, and the BILAC score, the SF36, none of that really was different in people who got rituximab. But I think what the take-home message here is that anti-dsDNA, the C3, C4, all were low in patients who got rituximab. That's some sort of an understanding or a signal we got. And more gratifying result, this is more of an exploratory analysis. This is not a predefined primary or secondary endpoint. So what they saw was at the end of 1.5 years, there was a significant difference in protein excretion. So what it probably tells us is that the immunological injury does not really, the prevention of immunological injury does not really translate into improvement in proteinuria, and it need not be. Like we all know that whenever we give modified Ponticelli regimen to a membranous, at the end of say 3-4 months, we really don't see the patient going into remission. There's only a minority of them go into remission in that particular period. But even after the completion of the therapy duration, we see a lot of them go into remission over the next few months. So we don't define treatment failure in that month when we stop the therapy. So there is a lag period between end of therapy and also remission. That's why all the trials always want to follow the patients even after the induction period is over. And I think here the rituximab did reduce the immunological damage, but it did not translate into reduction in proteinuria in the time frame of study, that is 1 year, 6 months. And it did cause less renal injury after some time. So there's a little lag time. And so any trial which tries to say whether it's useful in organ preservation or mortality reduction should actually think about a longer period of follow-up rather than look at 6 months, 1 month, or even 1.5 years of follow-up. So there was significant reduction in improvement in complete and partial proteinuric response in people who took rituximab. So that's a positive news. But then as per the predefined primary endpoint, it was a failure. And sometimes meta-analysis throws more light than individual studies, however well done they are. So we are looking at refractory lupus, a 31 study meta-analysis which enrolled more than 1,000 patients. So the overall global complete partial response rates in these refractory lupus cases was gratifying, 72, 46, and 32 respectively, which is pretty good. And also not only that, there was an improvement in SLEDAI score, BILAC score. The prednisone dose was significantly reduced with the rituximab treatment in both SLE with and without lupus nephritis. The proteinuria was lower in SLE patients and also patients with active lupus nephritis. The infection and infusion-related reactions were the most common side effect, and it was not too much. But so this again, the pictorial representation of what I said. So this first one shows the BILAC score is low in SLE and lupus nephritis patients. The SLEDAI score is low in patients who got rituximab. The dose of prednisolone was more achieved. The reduction was achieved more in rituximab group, and also proteinuria was more in the lupus nephritis group. So summarizing, the rituximab use in SLE is, it is of some use in patients with refractory lupus, and we should not forget rituximab as a therapeutic option. And it's definitely also should be considered in whenever we have serious lupus flare, and we need not always look at cyclophosphamide alone. Rituximab may be of some use in for faster prednisolone dose reduction. So that's what the people managed to do it both in LUNAR trials and as well as in the meta-analysis we found. The effect, and also it may be an induction therapy, but then both the LUNAR trial could not, and RAVE trial also could not help us in that. But maybe A better trial design may tell that it may become part of the induction regimen, but as of now, they are not. The effect of rituximab may be apparent after 18 months. So any trial which we may do in future should keep this in mind. The infection and injection related adverse events are definitely there, but they are acceptable. Going on to the second half of the presentation, so rituximab in vasculitis. So here it is much more defined, so much so that rituximab is part of a standard of care for induction therapy in patients with life-threatening and organ-threatening vasculitis, and with a good quality evidence based on published literature. And rituximab is better than cyclophosphamide in PR3 ANCA positive vasculitis. So that's what the RAID trial the HADOC analysis showed. So we all know PR3 ANCA positive patients generally have more severe disease and more flares, and rituximab group have fared better than cyclophosphamide group in this trial. And rituximab is also useful in treating relapses. In patients who are on cyclophosphamide, we can use rituximab, and people who are on rituximab, we can use cyclophosphamide. And unlike cyclophosphamide, where we have cumulative dose problems, rituximab, it may not be there as long as we monitor hypogammaglobulinemias and leukopenias. And as like Dr. Chekab showed to us, probably even a lower dose, we may get away with treating these flares. And also, rituximab may become the standard of care for maintenance therapy also, because I use for primary antiphospholipid antibody syndrome, I use rituximab 100 mg per once a year as maintenance therapy with absolutely no immunosuppression. They only get the other cocktail, but no immunosuppression. And similarly, rituximab has been tested as maintenance therapy. And they, as per the EULAR recommendations, azathioprine continues to be the choice agent for maintenance therapy, followed by rituximab, then methotrexate, then mycophenolate. Mycophenolate is the least preferred as per the recommendations. Azathioprine gets 96% vote, and rituximab gets somewhere around 60%. Methotrexate and mycophenolate less than that. And we all know that in RAID trial, rituximab was alone used, whereas in the group which got rituximab for induction, and whereas cyclophosphamide group took azathioprine, and they had comparable relapse rates. So rituximab can be used as maintenance therapy. And again, this trial showed that when the cyclophosphamide and glucocorticoid regimen after the induction, people were assigned to rituximab on day 0, 14, and at end of 6 months, 12 months, 18 months, or daily azathioprine. And then it showed that rituximab, when used as maintenance at 6 months, 12 months, 18 months, the relapse rates were much less. The complications, adverse events were less. And so rituximab can be part of a maintenance therapy, and it's only 6 monthly injection. And of course, for refractory cases, cyclophosphamide or rituximab can be used. Whenever we are using this cyclophosphamide-based regimen, we have to switch to rituximab and vice versa. And the caution is we have to check around 15 to 25% of them can have hypogammaglobulinemia, and these are the people who are more likely to have severe infections. And so it has to be checked before we give the repeat dose of rituximab, especially when repeat dose are planned. And influenza, pneumococcal, zoster vaccinations. Especially if zoster is available, I think we should put, because many of these vasculitis patients can be elderly patients also. So vaccination we shouldn't forget, and influenza vaccination does not cause flares. And ANCA titers B cell measurement are useful only after 6 months after therapy. In the first 6 months, these measurements do not guide us therapy. And ANCA titers and B cell measurement predict flares after the 6 months after. So during the initial period, these monitoring titers or the B cell measurements do not contribute or do not predict flares. So summarizing, rituximab is useful for in vasculitis for induction, treatment of relapse, refractory vasculitis as a maintenance therapy, and it is better than cyclophosphamide in PR3 ANCA positive vasculitis. ANCA titers and B cell measurement useful only after 6 months after therapy. Monitoring for hypoglobulinemia before rituximab dose is good practice. And don't forget to vaccinate and mitigate the CVD risk in these patients. Thank you. Thank you all.
Thank you, Raghavan. So we have really opened up a wide field for this molecule, and I'm sure the audience who are in large numbers will understand that rituximab has got a definite place in the armamentarium of a wide variety of renal diseases. So we have close to 6 to 7 questions. Before going to those questions, I would like to have a short commercial break, I will say. I will caption it. And then ask the MCure people as to what is the cost of their molecule right now. How are they pricing it?
So we are offering, good evening, sir. I am Sam.
Yeah.
I'm from the marketing team of
Yeah.
MCure. So certain patient assistance programs available for people who need rituximab. So if you go by the MRPs, the MRP is quite high, but under the patient assistance program, we offer it at a very affordable rate to all these patients. And in certain cases, if the patient is very needy, these rates can be brought down further for these patients. So based on the need, we can definitely work out a good pricing for the patient who requires.
Thank you for the great diplomatic answer. So that's nice. Okay. So we'll go for the questions.
Yeah.
There was a question from Ganesh Prasad. Is use of rituximab in SLE with encephalopathic manifestations will be a cause of any concern? Curiously, this was a typical scenario that I had encountered in one of my patients who I had used rituximab for a very resistant lupus. And then he came down with an altered behavior. And we had to, CT and MRI revealed that he had a herpes simplex encephalitis involving the temporal lobe. So you can have tricky presentations of the viral diseases in rituximab use. Fortunately, the patient recovered beautifully and they had undergone a transplant, is doing well. The second question that he has asked is about the panelist experience in congenital nephrotic syndrome. What is the least age of use of rituximab by the group? I wouldn't think that congenital nephrotic syndrome will budge with rituximab. Maybe Jacob, do you have any experience?
I have not tried it, but I don't think it will work.
Yeah. He had also asked about the anti-rituximab antibody test availability in India. I don't think it is available. I may be corrected, but if anybody knows that it is available somewhere, possibly it will be useful. But I don't think in the clinical scenario, that we are using rituximab for short periods of time. This anti-rituximab antibody is really going to matter. Again, about the excretion of rituximab in the urine in nephrotic syndrome, Dr. Edwin was alluding to that.
Yes.
There was another question from Prabhu about use of rituximab in membranous nephropathy patients with high antibody titers, levels above 150. Dr. Edwin, do you have anything to say on that?
Actually, nobody has really formally studied the levels and the dose to be recommended. So we really do not know.
Yeah.
Probably,
in fact, the levels are also not freely available. I see most often we go for either the plaque testing of the biopsies or with the help of the liver cells we do the plaque testing, isn't it? The indirect immunofluorescence, the titers.
No, the serum levels could be checked
Yeah.
Especially monitoring. It may be useful.
I think a few.
It may predict a relapse, or it may even give us some clue that remission is going to happen when the serum levels of the anti-PLA antibodies go down.
Yeah.
But the thing is, again, we must have standardized this test, and it's a little erratic in whatever I have seen. So we should have a lab that is exclusively, or somebody is exclusively looking into this particular aspect of the anti-PLA serum antibodies. But what's been recommended is when somebody's got a severe nephrotic syndrome, it is recommended that you go with a high dose of Ritux, a 1 gram dose of Ritux. The other thing is, if it is into the serum, if you find high titers of anti-PLA antibody in the serum, it means it's actually a spillover after the sink. So whatever binding happens in the glomerulus, and then whatever you find in the serum is one that's actually coming in after that. So a high level would indicate probably that we must use a higher dose of Ritux.
Question from Ramasamy Sethraman about the length of effect of rituximab depends on the background dose of steroids. I feel so, because rituximab and the steroids and mycophenolate, all these have an effect on the B cells. And so if you are going to have only rituximab, I don't think that you will have a longer remission. You need to follow. Again, multiple studies have shown that when you use rituximab along with background steroids or MMF, then the relapses are very widely spaced, and you are able to get a wide remission period. Whereas it is not so when you use only rituximab and stop with that.
And Sampath sir will also recollect that for steroid-dependent nephrotic syndromes, you actually induce remission with steroid and then only give Ritux.
Yes.
So, which means that there is an effect of steroid, and that is actually maintained with Ritux.
Yeah, you're right. So Bala has sent a letter of appreciation about Dr. Jacob's great work. And there was another question about the absolute serum creatinine level for avoiding rituximab therapy from Dr. Anita. Do we have any absolute level, or do we go by the biopsies and the clinical profile where we think that there is a point of no return, where rituximab is not going to have any benefit, and in fact it may aggravate the side effects, just like how cyclophosphamide is hold off when the creatinine goes up beyond, say, 3 or 4 milligrams. After that, I think it is all fibrotic tissue and you are not going to gain anything.
The study that I quoted, that it was useful even in stage 3 and stage 4 of CKD. But that's again a very small study, about 14 patients only.
About ischemia, reperfusion injury, are there any experience of rituximab? I really don't know, Ganesh.
Actually, there is, I don't have any personal experience, but there is a Korean study which says in 2012, I just saw in transplantation, that there may be a role of rituximab in preventing reperfusion injury. So we don't know, not much after that, not many papers.
I think we come to the end of this highly stimulating discussion on this molecule, where not much light has been focused on in the recent webinars, at least. So I think we'll close down, and I'll leave the floor to the MQ. Thank you.
And I think, Sampath, I would again like to acknowledge Jacob's work. I think it is path-breaking work, especially from India. And it has given us some insight and also some sort of evidence we can use low dose. I mean, all of us in our mind know that we could use low dose, but there is a lot of confidence after listening to your talk. Thank you, Jacob, for the excellent paper.
Very well said.
And
so I think
I learned a lot from your paper.
Yes. A round of applause is in order.
So,
Thank you, Mandan.
So thank you, Sampath sir. In fact, we are very thankful on behalf of MQ Pharmaceuticals for you helping us select this wonderful topic for use of rituximab in the various fields of nephrology. Sir. We saw it SLE vasculitis, we saw it in transplantations, we saw it in the membranous nephropathy cases. And we are also thankful for Dr. Jacob George, sir, because he took up his own study, which is done on the exclusively on the Indian population, which I'm sure is going to help a lot of us who attended this session today, the young nephrologists who are coming up, who are doing their DNBs, DMs, and it's going to help shape the future of nephrology in India in a better way, sir. So from MKO, sir, we thank you very much, and we hope to see you all again very soon.
Thank you.
My pleasure.